Have you ever wondered how a seemingly simple injection can provide some seriously profound pain relief, even in the toughest cases? Well, today we're diving deep into the Erector Spinae plain block, or ESP block. It's a real game changer in modern anesthesia. So whether you're gearing up for your FRCA exams or you just want to stay on the cutting edge, this explainer is for you. We're going to break down everything you need to know. So here's the game plan. First up, we'll get into the basics. What exactly is an ESP block? Then we'll dig into the fascinating and kind of debated science of how it works. After that, we'll look at the hard evidence from clinical practice. Where is this thing really making a difference? Then we'll get into some of the tougher questions, the stuff that will really make you shine in your exams. And finally, we'll wrap it all up with the key takeaways you've got to remember. All right, let's kick things off with section 1. What is the ESP block? I mean, this technique has had a meteoric rise. It's gone from a brand new idea to a totally mainstream procedure in just a few short years. It's pretty incredible. And look at this graph. It really says it all, doesn't it? Since it was first described back in 2016, the number of publications on the ESP block has just exploded. This tells you it's not just some passing fad. It's a major development in regional anesthesia, and that's exactly why you need to know it inside and out. Okay, so what is the ESP block in a nutshell? It's an interfacial, paraspinal plane technique. Let's break that down. Interfacial just means we're injecting our local anesthetic into a potential space between layers of tissue, not aiming for a specific nerve. And paraspinal means it's right alongside the spine. The real key here is our target, that space just deep to the erector spinae muscles. Speaking of which, here are the muscles themselves, the erector spinae. This is a big, powerful muscle group made of 3 different columns that runs pretty much the entire length of your spine. And that huge area of coverage, that's the secret sauce. That's what gives this block the potential for such widespread pain relief. And this slide, this is where it all comes together. On the right, you've got this perfect little schematic of the muscle layers. Our whole goal is to get that needle tip right onto the transverse process, just underneath the erector spinae. Then, on the left, you can see what that actually looks like on an ultrasound. Being able to recognize these layers on the screen is absolutely critical for doing the block successfully. So we know what it is and we know where to put the needle, but how in the world does it actually work? Well, that is the million-dollar question, and we're going to tackle it in section 2. And believe me, the answer is not as simple as you might think. There's a real debate going on here. The main theory goes something like this. The local anesthetic we inject doesn't just sit there. It's thought to spread forward or anteriorly through these little connective tissue pathways, and eventually it makes its way into the paravertebral space. And that's the jackpot, because that's where it can numb the spinal nerves, giving you relief from both superficial, somatic pain, and potentially that deep, visceral pain coming from the organs. And check this out. This MRI from a live patient is some seriously powerful evidence for that paravertebral spread theory. I mean, you can clearly see the contrast lighting up the paravertebral space, the little holes where the nerves exit, the neuroforamina, and even getting some spread around the epidural space. This is an awesome demonstration of the block's potential reach in a real living person. But here's where the debate really kicks in. The evidence is actually conflicting. While you've got these amazing imaging studies and some cadaver work that shows spread into the paravertebral space, other cadaver studies found something totally different. They saw the dye spreading way up and down the back, but almost none of it went forward into that crucial paravertebral space. Now, this could be due to the fact that cadavers don't have normal tissue pressures, but it's a really important controversy to be aware of. Honestly, this is a perfect point to bring up in your Viva to show you're thinking critically. Okay, so the mechanism is still a bit of a mystery, but the real bottom line is, does it work on actual patients? In section 3, we're going to look at the clinical evidence and see where the ESP block is really making a difference. One of the biggest wins for the ESP block is in treating rib fractures, and this is a huge deal. Mortality from multiple rib fractures can be as high as 33%, mostly because the pain stops people from breathing deeply. The block works so well that some major trauma centers now use it as their first-line regional technique, especially when things like epidurals are too risky. And it looks like leaving a continuous catheter in is even better than just a one-off injection. And get a load of this number. One key study found that in the first day after an ESP block, patients with rib fractures could breathe in an extra 545 milliliters of air on average. Now, that's not just a better pain score. That is a massive, tangible improvement in their breathing that can help prevent pneumonia and literally save lives. That's a statistic you'll want to remember. The evidence is also really solid for thoracic and breast surgery. For minimally invasive lung surgery, or VATS, studies show the ESB block leads to less opioid use and better pain scores. Same story for breast surgeries like mastectomies. But it's really important to have a balanced view, right? One study actually found that for radical mastectomies, a different block, a modified PEX block, was even better. So the ESB block is a fantastic tool, but it's not always going to be the #1 choice for every single operation. The block also has a couple of other really cool applications. In cardiac surgery, its biggest selling point is that it's safe in patients who are fully anticoagulated, which is a massive advantage over an epidural, and the pain relief is comparable. Then for abdominal surgery, its superpower is the potential for visceral analgesia, pain relief from the organs themselves. That's what sets it apart from other abdominal wall blocks, like the TAP block, which really only cover the pain from the incision. Okay, let's move on to Section 4, Unanswered Clinical Questions. This is where we get into the nitty-gritty, the advanced stuff, the kind of details on dosing and technique that show you've got a really sophisticated understanding of this block. So a really common question is, how much local do you use? And while there's no single right answer, this dosing guide here is an incredibly high-yield tool to know. It gives you a practical, evidence-based place to start based on patient weight. So for, say, a 70-kilo patient getting a block on one side, you'd think about using 40 mils of 0.25% bupivacaine. This is a great little cheat sheet to have in your mind. And what about the actual technique? We know our target, that spot on the transverse process, but what's the best and safest way to get our needle there? Now this is a brilliant advanced tip. The classic way to do this block is with the probe in a parasagittal position, like on the left. The danger here is something called lamination. Basically, you can accidentally inject into the muscle itself, and because the muscle fibers are parallel to your view, it can look like you're in the right spot, which can cause your block to fail. But if you turn the probe transversely, like on the right, you're now looking across the muscle fibers. An intramuscular injection is way more obvious, making it so much easier to avoid. It's a subtle point, but a crucial one. All right, let's pull it all together in our final section, the summary. If you remember nothing else from this explainer, this is the stuff you absolutely need to have locked down for your exams. So here's the bottom line. The ESP block is versatile, it's safe, and it's relatively easy to learn. Remember that debate about how it works? Paravertebral spread is the theory, but it's not totally proven. Its strongest use cases are for pain in the chest and trunk. Think rib fractures, VATS, and cardiac surgery. You should definitely think of it as a great alternative to an epidural or a paravertebral block, especially when those are contraindicated. And last but not least, always have your critical thinking hat on. A lot of the early excitement was based on case reports, so be aware of that potential for publication bias. And, this quote from the original article just sums it up perfectly. The ESP block should be considered an alternative analgesic option for patients with pain in their trunk. It's now a fundamental part of the modern anesthetist's toolkit. And that leaves us with one final thing to think about. As more and more evidence comes out, where is the ESP block ultimately going to land? Is it going to be so good and so safe that it actually replaces traditional techniques like epidurals? Or is it going to settle in as a really valuable but maybe more niche alternative? That's the big question for the future. All the information we cover today comes from the Erector Spinae Plain Block, a review of current evidence. It was Anesthesia Tutorial of the Week number 414, published back in December 2019. If you want to dive even deeper, I definitely recommend giving it a read. Thanks so much for tuning in.